Welcome to today's webinar. My name is Dr. Sarah Dalton. I have a clinical background in paediatric emergency medicine and a long history of healthcare systems improvement roles. I'll be your host for this session and thank you for joining us. Before we begin, I'd like to acknowledge the traditional custodians of the various lands on which we are meeting today and pay my respects to elders past, present and emerging. The country on which we are meeting is the Gadigal land of the Eora Nation. We're delighted to have you with us as we explore how the clinical care standards have helped 5 healthcare services achieve meaningful improvement. Thank you to everyone who submitted questions during registration. It's really helped shape today's discussion. It's now my great pleasure to introduce Conjoint Professor Carolyn Hullock. Carolyn is the Chief Medical Officer at the Australian Commission on Safety and Quality in Healthcare and provides executive leadership for the Clinical Care Standards Program at the Commission. Carolyn is also an emergency physician in Newcastle, New South Wales. Welcome, Carolyn.
Thank you, Sarah.
Carolyn, it's wonderful to see you here today and a really important and exciting moment for us to celebrate. I wonder if you could start by telling us a little more about the Commission and the clinical standards that we're here to talk about.
So the Commission's role is to lead and coordinate safety and quality in healthcare for the country. And I think we've got a really important role bringing everyone together to think about how we can improve patient care. We collaborate with many different parts of the system, so the clinicians, the patients, the healthcare organisations, in order to improve patient care. I think the clinical care standards are a really important part of that, and it's amazing that we're now 10 years in, but I think it's the way we think about clinical care standards, I think, is that it needs to be a really important priority for the country in terms of healthcare. We need to have a really strong evidence base that if we tackle this problem, that we can improve things, and there needs to be some understanding that there's variation across the country. So when we think about the clinical care standards, we're not necessarily thinking about big hospitals, but we're thinking about all hospitals, all systems across the whole system. So will it work in a rural and remote community? Will it work in the big cities? And what's important for patients, and what are the gaps in safety and quality?
That's one of the things that I love about the standards, is that they are really evidence-based, but they are also very applicable wherever you're working. And I think we can see that in these examples that we're going to talk about today, which is truly exciting for the future of healthcare. I wonder if you could say more about what you've noticed about these projects and some of the themes that you've noticed that resonate with you.
So we were really keen to celebrate 10 years, and I think a lot of people come to us and say, can you tell us what good looks like? So we sent messages out to the system, and we got a lot of applications, and they were all amazing, I have to say. But I was really impressed when we looked at who should be the award winners today, was the breadth of applications across clinical topics, but also across health services as well. And also the different and innovative things that they were doing to improve the system. I think that's the thing that really struck me, was the breadth of passion and thoughtfulness across the country.
I love what you said about the diversity, because we have projects that we're about to hear about from all around Australia, all different clinical services, lots of different clinical standards. And I also do want to pick up on what you said about all the great work happening out there that didn't get to be here today. And it's really heartening to know the standards are supporting that great work happening throughout Australia. I wonder if you could say a little bit more about what these diverse groups have in common when it comes to leading successful improvement projects.
I think one of the things that really struck me is collaboration, and I suppose I know from my own experience, when you're trying to make improvements in the system, is that you actually need to bring in a whole lot of different people to come together for a common cause, and I think that's one of the things that struck me. Like there's different kinds of health professionals, allied health and nurses and doctors and pharmacists, but also that they've got good connection to leadership too, because I think as an individual it's actually very hard to make difference to the system, it requires a team, and that's often a bigger team than we necessarily recognise.
Thanks, Carolyn. I mean, collaboration is the key to success, and I also want to pick up on the concept of leadership and the support of leadership. Could you say a little more about how you think that impacts improvement and what we can learn from these stories today?
I think the role of leadership is around enablement, actually, and empowering of the staff. So often people who are working on the front line have got really strong ideas around the things that we need to improve, and they're the ones that are in the system 7 days a week, 24 hours a day. But without the right leaders that can be there to support them, who kind of maybe have a bigger picture view of the world and the system, without them, it's very hard for an individual or for even a small team to get the changes that are required. And the good thing about the standards is because there's 19 of them and they're the really big important topics, we can actually then take it not only from a grassroots level but to a national level as well.
You're starting to talk about spread and sustain. So how do we share these messages? How do we keep the good work going? And we will be hearing a little bit about that today as well. Could you then finish perhaps by saying a little bit about what your observations are or what you've learned over the years about the best ways to help these improvement projects stick?
Yeah, I think it's embedding it into everyday practice, and it's not making it something special. It becomes the way that you work, and I think thinking about how you actually do that, so that it's not extra work or more work, but it's just the work. I think that's a really important thing, and I think as clinicians we often think about the ways we could do things differently, but it needs to be more systematic than that, I think. Yeah.
And evidence-based, and then it really does take a village to change the way we do things around here. But that's what we're going to hear about today, the teams that have done so much work to improve the care of patients where they're coming from.
And I think another thing that happens is clinicians, particularly doctors, are very passionate about their area of interest, and they've got a really good understanding of the evidence. And I think sometimes they can want things done the way they want them to be done, but it's also recognising that the evidence is bigger than the individual, and that if we all agree on something, we can move forward. So I think that's one of the other things I think I've learned, that it's not just the evidence, but it's how the evidence is interpreted and embedded within the team.
And engaging hearts and minds, I think, is a challenge that we'll also hear about, and obviously people have done that really well. May I use that as an opportunity to ask you about how this makes you feel to know that you're at 10 years and that clinical care standards have been guiding care across Australia for all that time?
Oh, I think it's remarkable. I'm so proud of it, and it's a great, I feel like I've been a clinician for many years. I've led teams for many years, but to actually being able to have an impact at a national level and know that the small hospitals, the big hospitals, the community, that we're all actually working together is a pretty remarkable thing.
Thank you so much, Carolyn. Before I let you go, I'd just like to ask one more question, which is, on behalf of everybody listening, what are the other things you'd like to say or leave people with in terms of recognising the extraordinary work that's done across Australia every day?
Oh, I think we have an amazing health system in Australia, and of course there's always things that we can do better. But all in all, the vast majority of the time people go and seek healthcare and get really good healthcare, and we should be really proud of our health system.
Thank you, Carolyn. Is there anything else you'd like to share?
I think a huge congratulations to all the teams across the country that have put in submissions for this 10-year anniversary of the clinical care standards, but particularly congratulations to the teams who are the award winners. It's impressive work and we're really proud of it.
Well, thank you so much. My personal thanks to you in your role and to the Commission, but also to everybody who has submitted their abstracts for consideration for this project. I think that it's important to recognise and congratulate everyone who submitted their work, and to continue to keep doing the great work that you have, knowing that the Commission is behind you and supporting you all the way. Thanks very much. Well, now it gives me great pleasure to introduce the award recipients: Elizabeth, Sally, Janine, Michelle and Emma. All clinicians who bring diverse perspectives on safety and quality. Thank you for being here today. I'm really looking forward to a wonderful discussion with you. So we're going to move through the 5 key themes which are enablers of successful improvement. As you know, the first one is collaboration, second is measurement, third is integration, fourth is engaging leadership, and fifth is sustainable change. I'm really looking forward to hearing from you about these. And I'll start with you, Elizabeth, and ask if we can just hear a little bit about your name, your project, your title, and what you're proud of about your project that you've been working on.
I'm Elizabeth Sue. I'm a senior pharmacist with the Medicines Optimisation Service at Austin Health in Melbourne, and we implemented a digital tool to help our prescribers to document their prescribing intentions at transitions of care. And we're really proud because since we implemented the tool, it's really helped to improve our documentation processes.
Thank you, Elizabeth. I'm looking forward to hearing more about it. Thank you. Sally, welcome. I wonder if you could tell us about your role and your project.
Thank you. I'm the support manager for clinical operations for the Northern New South Wales Local Health District. My role was a team member of the clinical care standard review process. So we had a quick turnaround to really revise our clinical care standard practice across the district. So a lot of our work was involved bringing a team together quickly to make some big improvements.
Fantastic. And again, looking forward to hearing more about how you brought everybody together.
Absolutely.
Thank you. Janine, welcome. Let's hear about you and your story.
So I'm Janine Connell. I'm Director of Nursing within the Flinders and Upper North Local Health Network in South Australia. I'm the lead of a sepsis working party within our LHN, Local Health Network, and we identified a concern with episodes of missed or delayed diagnosis of sepsis. So we set about implementing the clinical care standard in 2022 and worked towards tailoring our sepsis pathway and measurement strategies along that line to improve our outcomes.
Fantastic. And I know everyone cares a lot about sepsis.
Absolutely.
Looking forward to hearing more. Welcome, Michelle.
And so I'm Michelle Clark. I'm the Stroke Service Coordinator at University Hospital Geelong Bowen Health. We're a regional hospital located an hour outside of Melbourne. Our story is reducing our door-to-needle time for acute stroke. We have a target of 60 minutes and we worked on improving that treatment time in thrombolysis.
I'm looking forward to hearing your statistics. I think you've got some good news stories to share with us. Thank you so much. Welcome, Emma. Can you tell us a little bit about your role and your project?
So I'm Emma Whitney. I'm from the Canberra Hospital. I'm the Antimicrobial and Infectious Diseases Stewardship Pharmacist. And the project that we led was the implementation of the Antimicrobial Clinical Care Standards through a pharmacist-led audit program. And I'm really proud of the impact that it's had on patient care for our population.
Fantastic. It's great to hear about the impact. Welcome to you, Emma. All right, well, let's get started and hear about some details of these projects. We'd like to know what happened, but we'd also like to know how it happened and what was learned along the way. So I am going to start by talking with Michelle about stroke. And I wonder if you could just expand a little bit on your introduction, Michelle, and tell us more about the problem that you were trying to solve and how you went about that in your district.
We received our 2022 OSCAR annual report, which showed that only 19% of patients were thrombolyzed within the 60-minute target. We were well below the national benchmark of 75%. And our average door-to-needle time at the time was 71 minutes. So we started off with building the foundations for any quality improvement project is building relationships and collaborating with all stakeholders that were involved in the stroke code processes. And this involved Ambulance Victoria, ED, the stroke team and medical imaging. And we looked at where our delays were occurring in the stroke code processes and how we could further improve on our timely treatment.
Thank you. You've already mentioned quite a few stakeholders who were involved with your project, and the key theme here is collaboration. Can you say more about how you brought people together and what you think was a successful strategy for collaboration?
Implementing regular stroke service meetings was key for improving our processes. We relied heavily on key champions amongst each department, where we had an opportunity to catch up in these meetings and look at our live data, compare it with national benchmarks and targets, and start looking at the steps during a stroke code process and where we can further improve and implement some changes. And this was a lot about understanding each other's roles and responsibilities in these stroke code processes, and understanding the competing pressures that we all face in the emergency department. Stroke's only 5% of the workload, and so we needed to appreciate that and work out how we can all come together to improve this patient's outcome.
Thank you. It sounds to me like you did a lot of putting yourself in someone else's shoes. Can you say more about how you did that or how you helped people see those different perspectives?
Yeah, sure. So I guess understanding that we need to prioritise the patient care at the time is our priority, and understanding that we have systems in place that we must follow and embed in our local practice. So heavily relying on the clinical care standards, our targets and benchmarks, and networking as a team in order to make these improvements.
I think it sounds like you had a really strong team and really great teamwork. What do you think was one of the reasons that your team was able to bond so well?
I think sharing the same common goal that we want the best outcome for our patient, bringing it back to the priority, and that is the patient in that moment, and putting yourself in their shoes and what treatment you'd want for your loved one. And I think we all shared that same common goal, and that really brought our practice in place with the things that we improved on.
So I think that theme about patient care, patient focus, putting yourself in others' shoes is probably relevant for all of your projects. I wonder if there's something that you might say then about how it is that you got your teams to work together, because I think that collaboration and being able to get people on board is really challenging, and I know you've all been successful at that.
Agree. Bringing that team on board with that shared vision is a really key success to a change management project, and searching far and wide for those key stakeholders, like looking outside the box to see who else might have some information that can contribute positively to the project, I think is really beneficial to moving them forward.
Can you say more about looking outside the box? I think that's important and not something we're hardwired to do often.
No, absolutely. I think we know what we know, and we have to set ourselves outside the box, and even sometimes out of our comfort zones, talking to directors of medical services or leaders of streams to gather information from them about how they actually do what they do. Especially for my clinical care standard, we were looking at governance process, so we wanted to implement structure to processes that we need to understand what the clinicians were doing in those areas to be able to then understand how we could put that into a structured process.
Being outside your comfort zone sounds like a theme. Anyone want to pick up on that one?
Certainly with engaging with directors of medical services and pharmacists was important. With our work with sepsis, it was important to get pharmacists on board. So I think it's cast your stakeholder net very wide. You'll be surprised where the champions will come from. And we found that the medical staff were absolute champions, both the directors of medical services, but also some of the junior medical officers and GPs as well, and heads of emergency departments. Their contribution as champions and being passionate about our cause was really valuable to getting that impetus and spreading the word broadly to inflict change, to make change happen.
Yeah, I mean, I think that the different perspectives people bring can make the project better, and I'm sure that you'll each speak to that. But also as the team comes together, and as what happened with you, that team bonding and the team purpose, that then creates momentum and energy, and then other people want to get on board, which is probably where you're all at now because you had such successful projects. Thank you so much for sharing your story, Michelle. I think we'll come back to that and hear some more of your story as we go through some of the others. So Elizabeth, I'd like to now move on and hear more about your story, and with a particular focus on monitoring and measurement, which I know was a big part of what you did. Could you tell us a little bit about where you were coming from and why your team set up a project and what they did?
Yeah, so what we worked on was implementing a tool to help our doctors to document their intentions when they were prescribing opioids in acute pain. So being a major metropolitan hospital, we do have many patients who come through our ED and our surgical services getting started on opioids. And as we all know, the thing about opioids is they can be really effective for pain, but if you're using them for longer than they're needed, you're putting the patient at risk of side effects and also developing problems such as dependence and addiction. So it was recognised by our service that it was really important, especially when patients were leaving our hospital with prescriptions for opioids, that we were very clear about what those medicines were being used for and how long to use them for, and to communicate that information to prescribers in the community so that things wouldn't be prescribed for longer than they needed to be. So that was what we really wanted to work on at our hospital. So we brought together a group of, people who are very passionate about opioid safety together to ask about common roadblocks and issues. And one of the things that was identified was this issue of communication on discharge. How can we help our really busy doctors within the ED and our surgical spaces to write down the information that they want to in a really efficient way that wouldn't slow down their processes? So to help with that, what we did was we led the implementation of a digital tool within our electronic medical record to make that documentation process as accurate and as efficient as it could be, so that the right information was getting to the GP each and every time we prescribe opioids.
I love the way that you've hit on that topic of make it easy.
Yes,
the
that's
easier
right.
you can make it for people, the more likely they are to do it. And not because they're lazy, because they're busy.
That's
and
right.
It needs to be intuitive and easy to pick up. So I'm sure we'll hear more in the other projects. But what I'd love to know then is, once you implemented this tool, how did you know it had been successful?
Yeah, so I guess one of the things that we tried to do when we were planning this particular intervention was really build a way to actually monitor what it was doing, because I guess it's well and good to create something, but if it's not being used, then it wasn't really worth the effort. So when we were creating this digital tool, what we also did with our business intelligence units and the electronic medical record team at the hospital was to build a dashboard and also some monitoring reports. So we could actually see the tool that we'd developed, whether it was being used. So for the patients who are being prescribed opioids, whether the tool had been used to document a plan, whether that plan was in the patient's notes, and whether it had gotten into the discharge summary where we were hoping it was going to get to. So having that tool available to us during the implementation phase of the project helped us to, figure out whether there were any roadblocks in the workflows that were affecting our prescribers and clinicians on the ground. And also having that dashboard as well has meant that a few years down the track, we can still continue to keep an eye on the workflow and to help our clinicians where needed.
I think what I heard there is actually collaboration around management.
Yes.
Measurement. So getting people on board to help design the right tool and then get people to watch the tool and monitor the data sounds like a big takeaway for your project.
Yeah, that's right. So I guess a lot of the monitoring does get done by the clinicians in my service. So we're a group of doctors and pharmacists who work on medication-related issues, and we do have an ongoing opioid analgesic stewardship committee. So if we do notice anything interesting in our monitoring dashboards, that's the committee and the way that we can report some of these issues and discuss solutions and ways forward.
And I'm guessing that your panel members are listening to you thinking about monitoring and measurement and digital tools, because I think that's another common theme. I wonder if I could hear from one of you about what you learned about the importance or the effectiveness of digital monitoring and how you get that to work.
I think within my health service at Canberra Hospital, we use a digital health record, and obviously that integrated with the implementation of the tool that the Commission provided really made things easy for the pharmacists who are collecting the data out on the wards. But some feedback that we had around the data was that the clinicians and the pharmacists wanted more access to that, and they wanted to see it in real time. And so we were reporting either biannually or quarterly, and that wasn't enough. So now we're in the process of adding our data to our quality and safety dashboards so that we can make sure that those people that want to see that data can see it in real time, and then they can make decisions on that data.
Wow, real-time monitoring. Has anyone else got to that point?
I wish. We've got, in South Australia, we've got the Sunrise electronic medical record. And when we started this project, only one of our health units was using electronic medical records. All the others were on paper records. So the auditing was really quite cumbersome. So we were very reliant on our auditors having the passion to follow it through. And then 12 months ago, we all went on to electronic medical records, but the system doesn't give us the sepsis patient data that we need to audit. So it doesn't give us the right patient group. It's not able to get it out of the system. So there's a number of things we're doing. One, we get the data from diagnosis-related groups, and then we have to manually sift that to get the outliers and then go through an audit. And being on electronic medical records makes the auditing process substantially easier, but we're still not happy that we've really got the right patient group. So there are tools built into Sunrise for sepsis order set and sepsis alert. So one of our key pushes at the moment is making sure that every clinician accesses and activates that set. And once we are confident that we've got the reliable data going in, we've got a better option of being able to put pressure on the system creators to make it so that we can pull that data out. So it's a work in progress, but there are a lot of challenges in that space with data collection.
What sticks out for me is work in progress.
Yeah.
And I say that because I think for most people in the room, even with really advanced EMRs, it's something that will continue to improve. The other thing I was thinking about is how information is power. And I've heard it said, in God we trust, for everyone else bring data. Because you need to be able to really prove your story, don't you? And each of you been able to show improvements over time with the projects that you've run.
And that's another area. One of our medical directors said, if you want people to change, give them the data, which is why we developed a dashboard producing all our audit results and showing where we've improved and where we haven't improved. And that is really made widely available and pushed through all team meetings so that every clinician who is involved has got that information so they can see where the problem areas are and act to improve their performance in that space.
It's a fantastic,
and it's working well.
A fantastic point about not only looking where you have improved, but where you might still improve, and then where your hotspots are, where your opportunities are to make a difference. Thank you. Emma, I'd like to come back to you about integration. So we said before, make it easy. Obviously, you've done a lot of work in that space. Can you say more about your project and how you address that issue?
Yeah, so our project, as I've said before, was looking at antimicrobial appropriateness across our health service, mainly led by pharmacist-led audits. So integration for us, I think, had a few phases. Obviously, we had integration of the actual audit process with the pharmacists. So the way that we started that was that it's a monthly audit. So on the first Tuesday of every month, the pharmacists know that that's when we do the audits. They take 5 patients from whatever ward they're working on, and they assess the appropriateness of their antimicrobials. So once we started that audit process, about 2 years ago now, that really became integrated into their workflow, and it wasn't something unusual. And then, of course, you have to do something with that data. So then we had the integration of that data into the reports that we were then feeding back to the various divisions, which was either quarterly or then later biannually. And then, as I raised before, now we're moving towards having that real-time dashboard and being able to provide that data.
It's fantastic, I think, that you've also made it part of routine.
Yeah.
So it's part of daily work, but it's first Tuesday, very clearly first Tuesday. How do you help people understand and remember that?
So we have calendar alerts that go out to all the pharmacists, and usually a member of our team will also message in our pharmacist chat just to remind everyone that it's audit day and that we're available if they have any questions or they need help. And those wards that don't have cover for whatever reason, we check up and see if those areas need to be sort of supplemented or if they're sort of on track with the other wards, and we're doing okay across the board because we want to make sure that the data collection is fair for each division.
So can I ask you then, when you're collecting data about what's going well, but also where it's not going well, can you think, and maybe someone else might like to share their story, of where you had a challenge? Because there's always the people who go first and the people who go last. So can you share with us about how you managed that to make sure that the whole ship was moving forward, not just the motivated few, if you like?
Yeah, sure. I think for us, a particular area of focus was around antimicrobial allergy appropriateness. So we noticed across our health system that antimicrobial allergies weren't being recorded very well, and that was impacting the antimicrobials that patients could receive on the wards for sepsis or for whatever was going on with them. So as part of our review and part of our policy was there's an antimicrobial assessment, and part of that is an accurate and thorough allergy documentation. So we noticed that, and that can be a change of practice for people. So talking to, particularly in ED, talking to the nurses about what we expect for a thorough and complete allergy documentation so that we have the information available and we're not having to go back to the patients and reassess those allergies every single time we're looking at prescribing the appropriate antimicrobials for them.
I just want to say thank you on behalf of all the doctors who have been told that their patients have allergies when you really know they probably don't, but you don't quite know how to get there. So that's making it easy. I appreciate that. Can I come to someone else about a challenge and how you overcame it?
I think especially with the data entry, it has to be accurate. And when you've got multiple people entering that data, you want to make sure that everyone's got the same interpretation and definition of the indicator that you're monitoring. And especially for us, when we are benchmarking with other services, we want to make sure that we've all got the same interpretation of that data if we're comparing our data against other hospitals. And that can be really timely. It can be really time-consuming doing that education with your clinicians about data accuracy and how to just simply enter the data.
And having accuracy is clearly very important for all the reasons we said before about the information and the power that it has and how you can use that. But then also there's always detractors who want to tell you why it's not right or why it doesn't matter. Has anybody had an experience where they've had a successful strategy in overcoming detractors?
I think we had a little bit of resistance to change with our audit. We had an existing audit in place that had been in place for a few years, but we noticed those discrepancies with data entry. So some people were looking in this part of the medical record for information, other people were looking in another part of the medical record to find the information to address the audit. So really questioning the question, I guess, is what we looked at to then explain to people that we really needed to standardise across the district how we approach the audit questions to meet the clinical care standard appropriately. So getting to really understand that, you know, the most appropriate place to look is here, so then we're really capturing that genuine information that's going to make a positive impact on the care that we're delivering.
So it sounds like you were listening to the feedback and improving and continuously improving where you could, but at the same time required a fair amount of education and support, which is part of a change process, of course.
Absolutely, but it was good to involve those people in that process, though, to get their feedback. So where would you look for that information? Okay, so if I look there, what does that look like? So really having all those stakeholders involved in that conversation was really key to success.
So Sally, that's a great chance for me to ask you more about your project, and we're going to move on to engaging leadership and how engagement and leadership can make a difference, which you've already talked about. Maybe you could say some more about the challenge that you had and then how you overcame it.
Yeah, so our challenge for the colonoscopy clinical care standard was, can I say, thrust upon us. We were in the middle of an accreditation assessment, and we received a not met against the clinical care standard. So we were swift to called into action to really try and address the not met. We had 60 days to rectify the issues and the concerns that were raised by the assessor. So engaging our leadership team from Northern New South Wales Local Health District was key to our success. So the quality managers on the floor at the front of accreditation didn't know all the key stakeholders to be able to engage in this process, to be able to standardise across the district. So tapping into our leaders across the district to find out who are those people we need to talk to, whether it's directors of medical services, whether it was the proceduralists, the senior medical doctors, the directors of nursing and the nurse unit managers. So really spreading our reach far and wide to make sure we could gather as many of those key people together as possible, so then we could at least get a good starting point to then work out, okay, what do we need to do and how can we progress this forward within a 60-day turnaround?
I think what you've highlighted for me is the importance of what you might call the authorising environment or executive sponsorship, but the concept that you've got people who will stand behind and support this no matter what. But at the same time, many of you have talked about the importance of involving people at the front line who do the work all day, every day. And I think you do have to have the top down, bottom up in order to be successful.
Absolutely. It was a key to our success was collaborating with individuals from nursing staff on the floor who would enter the data into the collection system, to having those conversations with the proceduralists to understand that we're implementing a new governance system, so that's going to mean for them attending meetings, reviewing minutes, commentary on the data that we're gathering. So yeah, top to bottom collaboration is definitely a key.
Can I ask others about your experience of this? What did you learn?
Yeah, so I guess from our opioid stewardship point of view, I did mention before that, we'd had this round table bringing clinicians together to sort of say, what are the roadblocks that we would like to overcome? The thing about creating a system change, so like for example, trying to build a new digital tool within your existing EMR system though, it's a big change across an organisation, and you do need, I guess, from a top level down, governance support to really, get those sorts of changes across the line. So allocating resources towards creating the tool, but also implementing and the education around that. So what was actually really useful for us was actually the clinical care standard coming out. So from that, because there were very clear indicators of what was expected for healthcare organisations to meet, we could then use that particular indicator to say, well, it's clear that we need to have some action in this area, and that really helped to get some of our ideas across the line at governance committees and, yes, bring our thoughts into action.
Thank you. You've just highlighted something a few people have said, which is how the clinical care standard itself was absolutely integral in the change journey. Not only to be able to define the standard, but I guess to create the case for change, to get involvement, to allocate resources. Would you like to say more about how the clinical care standards enabled your success?
I think for us, we use the clinical care standards, and we also use the clinical guidelines for stroke management. We're very lucky in the stroke world that we have good current evidence-based recommendations out there that in lines with improving patient outcomes and what's the best care for that patient. And it really puts your priorities, it really highlights your priorities and gets rid of the background noise at times in the healthcare system. And it was a really good way to just focus on what matters the most. And then we could use these clinical care standards to implement changes in our local protocols and procedures.
I can see you nodding, Janine. What are you thinking?
Well, we use the clinical care standard and the self-assessment tool as basically our roadmap. We sat down with the self-assessment tool and identified what needed to happen and where our priorities were, and that informed our roadmap to move forward, to help us nail down the priority areas and actions to get to that point. And that really formed the foundation of all the work we've done. And I think moving forward, we've been going for about 2 years, a bit over 2 years now. It'll be very soon that we will revisit that tool as a ongoing evaluation and see where the changes have made, and to refocus our future work in different directions.
We've got this far in the panel without talking about the journey, but I love that you've brought roadmap, because I think that's very practical and action-based. And I am going to come back in a moment and ask you more about your roadmap, Janine. What I would like to do before we finish your story, Sally, though, is to think about the big change that you had going from a not met, which must have felt really challenging, to sitting at an award table. Can you tell me more about how that feels for you and the team?
Pretty proud. We've got a very excited team back in Northern New South Wales Local Health District. I think initially, I guess once the shock wore off of a not met and having to quickly respond in a 60-day turnaround, to being engaged in this body of work quickly, I guess being proud of everybody jumping on board to understand that we did have a quick turnaround, that we wanted to be able to do this quickly, to be able to demonstrate to the assessors, while not embedded practice just yet, we've made all of these changes, and this is our commitment moving forward, that this is where we're going to go. So yeah, from going from that not met to now being celebrated nationally is a pretty proud moment for us.
So I'd like to take a moment to congratulate your team, but all of your teams, because you've all had a journey a bit like that. There's the word journey. But I would like to ask you then, how did you get people to go from not met, which a lot of people might take as it's just in the too hard basket, we can never do it, to this fantastic change that you've enabled?
I think I'll touch back to our conversation we just had before about using the clinical care standard as a roadmap. It was my Bible for 60 days. It was really having a look at it. What are the genuine requirements? What do we need to do? And using that as, I guess, supporting the conversations we were having with the clinicians. So getting them to understand we're not asking you to do this just because. There's real meaning and purpose behind all of the activities we're trying to implement to be able to demonstrate that we meet the standard. And I think once they understood that it wasn't auditing for the sake of auditing or a new form for the sake of having a new form, that it actually contributed really positively to the outcomes of our patients coming to have colonoscopies in the district, I think the buy-in, it really generated momentum itself, people cotton on to the fact that we were working in this space and were happy to come on the journey.
And I was just thinking, we talked about how for our teams, the more you can make it easy for them, the more likely it is that they'll change. But also, it seems to me the clinical care standards makes it easier to implement change. And in different ways, you've all said that having that Bible, the roadmap, the meaning and purpose, you said, which is really amazing to be able to tap into that through what might just seem to be a document of standards, but can make a big difference when they're brought to life.
Absolutely.
So Janine, bringing clinical care for sepsis to life, and you've been on that journey. Tell us a little bit about how it started, but I'd like to focus a little now on where are you now and what comes next, and how do you make sure that these things stick? Because we know that you can have the excitement and the award and the have a cake, and then everyone goes back to normal. So where are you at now?
We're at the moment, embedding it as business as usual. So we've done the 2 years of banging the drum, if you like, and getting it forefront in everyone's mind. But we do, as routine, we share our audit results on a quarterly basis, and they're shared very broadly in high traffic areas. The importance of early diagnosis of sepsis is embedded in the orientation for all medical staff. So having that medical engagement again, the minute those doctors hit the door, that's part of what they're told is the importance of sepsis, where to get the sepsis pathway. It's a one-page document that we've adapted for our own purposes. So it's a one-page, step 1, step 2, step 3, with associated timeframes to meet the best practice for managing sepsis. And that's shared across the whole local health network. Moving forward from here, we'll be looking at discharge advice and discharge protection, or not protection, but supporting sepsis patients post-discharge and giving them information and about things like post-sepsis syndrome, and also moving on to changes within the maternal sepsis pathway and the paediatric sepsis pathway. So looking at having a deep dive into those as this work is focused on the adult sepsis pathway. So they're probably our key areas moving forward. Yeah.
And what do you see that you have in place now that is going to help you continue to sustain and improve on those gains?
Well, we've got the audit pathway, and we've got the audit sepsis boxes in the small health units, so that everything they need for sepsis is contained in one spot. It's embedded in medical practice. We'll continue with our quarterly audits and monitor those results. And where we see any deterioration in those results, we'll revisit that space. We do regular in-services with all staff, our teams across the whole LHN. We participate in Paediatric Sepsis Awareness Week in April and World Sepsis Awareness Week in September, and we have targeted displays in all health units. So it's not just one hospital doing it. We make sure each health unit has a display and work with promoting it into the community. So we see that as embedding that change in practice, that sepsis is your first port of call for diagnosing whatever's wrong with this patient, not when they think about later. So it's shifting that focus as sepsis is front of mind, not back of mind when you're initially treating a patient.
That's fantastic. And as I'm listening to you, I'm thinking the sustainability message that you've just shared with us is keep messaging, keep measuring, and keep motivating.
Yeah.
And they're all hard on their own, but you've already been doing that. Just
Yeah.
need to keep going.
And that's the thing, you'd be surprised where you find your people with a passion, and you get a few of them around the table and it bubbles out to everybody.
It's infectious.
It is.
If I can use that word in a healthcare setting. Absolutely. So when you're listening to this, I'd like to hear from others about how are you going to stay where you are and continue to improve, recognising that you've already come such a long way.
Well, I guess I might mention that with our opioid management plans that we've implemented at the hospital, so far they have been focused on the acute pain sector, or that group of patients. And I guess one of the things we're aspiring to do is also look at other patients who use opioids. So basically those with chronic pain, those who may have palliative care or oncology conditions. Those people also have to have this information about safe use of opioids communicated to their GPs as well. But the workflows in those particular areas are going to be different to the acute setting. So we're hoping to take some of the learnings we've had from our ED and surgical space and translate that to other areas of the hospital as well. So although the clinical care standard in acute pain has been really useful for us in quality improvement, that's not the only thing we're focusing on. It's really just the start.
What I was thinking is I think one of the reasons you've all been successful is you've been very focused and you've chosen cohorts where you can have influence and you've got fantastic stakeholders around that. But for all of you now, having been successful, you're going to be asked to do more and move to the next cohort, to go outside ED, to move to paediatrics. We'll hear from your others in a moment. But when it works, it's great and there's always more work to do.
Absolutely.
What would you like to add about how to sustain the gains?
I think something that we've been focusing on now is embedding antibiotic order panels. So we've developed 134 antibiotic order panels based off the therapeutic guidelines or our local policy, depending on our antimicrobial resistance in our area. And now it's getting clinicians to be empowered to use those guidelines. All they need to do is type in the condition, let's say, for example, community-acquired pneumonia. They would say, my patient does or does not have an allergy, and then they get the correct antimicrobials that are already set out. We've also embedded levels for high-risk medications, antimicrobials like gentamicin and vancomycin. So anytime those are ordered, those levels for therapeutic drug monitoring are embedded into the order set. So those levels will be taken at the right time, and then the pharmacist can use those levels to accurately assess whether those antimicrobials will be right for the patient. So I think for us it's really about engaging with the clinicians and making sure they're aware of these resources and things that they can use to ultimately improve patient outcomes.
So the work's never done. What about you?
Yeah, I think definitely just continue that communication and strong relationship building with your departments. There's a high turnover of staff that are continuously working through the emergency response team for us. So we really want to just make sure we're continuously feeding back the data that we have and reminding the team what the key focus is. And that's ultimately the patients and improving their outcomes. I think celebrate your achievements, celebrate your wins, recognise and value each team member in that process, because we can all make a significant difference.
Well, that's what we're here for, to celebrate the wins and to thank you all for making a significant difference, as well as reminding everybody that there are ways we can all make a difference every day. One of my favourite quality improvement sayings is that we all have two jobs: to go to work to do our job and to go to work to improve our job. And you all exemplify that so well. So in closing out this session then, I'd like to hear from each of you about some of your key takeaways and learnings. And there's so many, and can I thank you for sharing them in the way that you have already, because there's so much that we can take from this session. But if you were to summarise what you have learned as perhaps just one thing, because there could be many, many things, and maybe imagine that you're writing a book or a paper or you're writing a poster or something about your most important takeaway, I'd love to hear what it would be. And I might start at this end of the table and move back this time. So Emma, can I start with you? What would be your key takeaway or learning from this?
I think for me, the key takeaway from our project has been to close the feedback loop. some feedback that we received from the pharmacists and clinicians who were collecting the data was that they didn't understand where the data was going and what it was being used for. So that, obviously I'm looking at this data every day, and so is my team. We know what we're doing with the data. So feeding that back to them and helping them understand that they're not just auditing for the sake of it. They're not just filling out a form, that is actually making a difference. So yeah, close that loop.
Close the loop.
Yeah.
Thank you so much, Emma. Michelle?
I think the key learning is certainly, and today, acknowledging the passion that we all have for our areas that we work in, and sharing that passion with other clinicians that we work with every day. We are leaders and we can role model the correct behaviour in terms of what the best thing is for our patients that come in within our care. So celebrate your wins, share the passion to the team members that you work with, and value each other's role in that process.
And role modelling, I think, is super important. It's one of the things we know makes a big difference. So thank you for bringing that up as well, Michelle. Janine, what's your takeaway?
Be flexible and listen to everybody's point of view, because gems of wisdom come from sometimes the most obscure places. But be open to flex. Don't be fixed in your pathway, and keep it simple, because you're dealing with something that busy clinicians are managing, so they're not going to read a 7-page procedure or an 8-page procedure. Keep it simple, keep it a 1-pager with the key take-home messages, and share your wins and share your results. And that was one of the pieces of advice we got from one of our medical officers, was if you want people to change, show them the data, show them the numbers, show them where the gaps are, and they will change. So that would be one of my key take-home messages, is be flexible and be prepared to shift and change as the path goes along.
And adaptable. And the path will continue.
That's right.
Thank you, Janine. What about you, Sally?
I'd like to say collaborate, collaborate, collaborate.
Excellent.
We tend to say it a lot, but generally engaging in collaboration with key stakeholders that the change is going to generally impact in their practice, I think is a key to a success story. Tapping into all of those people's clinical expertise, whether they're the people doing the audits or the clinicians performing the procedure, to really understand what they do and how they do it, especially when you're someone from outside that area, potentially writing a policy, procedure or a guideline, to generally tap in and collaborate with them to understand what is it they do and how can we build that into the work that we're trying to achieve.
I think collaboration is one of the very key messages, but then also you both just touched on listening to people and their ideas, because there's gold there. You said something like you might not have thought about it until they bring it up. Sorry. So thank you both for reminding us of that. Elizabeth, what's your takeaway?
So mine's on that theme as well. So I think if you're trying to create a solution or create a change, really involve the people who are impacted by that change in that design and the solution making. So, creating interventions for clinicians by clinicians. So having them involved, they understand what the issues are on the ground, they understand their own workflows and what's going to work for them. If you can work with your clinicians to build your solutions, you're hopefully going to create a sustainable workflow that's going to be able to go on.
Absolutely. And we just said earlier and started out in that place of everybody feels the pain of a problem. And if everybody can be motivated by finding a way towards a solution, then everybody can celebrate success. And being able to involve everybody in different ways, but particularly listening to clinicians and having feedback in ways that can solve problems that clinicians care about, that makes a difference to patient care, then that's what we're all here for. Okay, well, I'd like to just close now by remembering all the key messages that we've heard from you all, because I think that we could write a book about quality and safety and implementing clinical standards, and these could be the chapters. The first one would be close the loop, and remembering to make sure you tell people what has happened. The second is share your passion, because passion is infectious and role modelling can make a difference. The third is be flexible and listen to everybody, because there's gold to be found if you just listen enough. Remember to collaborate, collaborate, collaborate We should have 3 chapters on that, I think, one each for each collaborate. Which brings us to the beautiful way you finished, Elizabeth, with being able to involve people in the solutions and remembering that this is for clinicians by clinicians. And that's what the clinical care standards are all about. We're all clinicians here, but we're all representing the clinicians that we work with who ultimately are here for our patients, and remembering that we're working together to improve patient care. So I think that brings us to the end of today's webinar. On behalf of the Commission, I'd like to thank Carolyn and all our panellists for sharing their time, their insights and their expertise. Thank you to everyone who joined us. We hope you found the discussion valuable and thought-provoking. If you'd like to revisit this content or share it with colleagues, please visit the links displaying on your screen now. Thanks again. We look forward to welcoming you to a future event. Take care now and goodbye.